Thank you, Mr. Chairman. Good afternoon, dear ladies and gentlemen. That's true, we were starting from different level, but we are also a country in former Eastern Europe, behind the Iron Curtain. And so we had something which was, I would call, intermediate level of care, but we wanted to be much better. And if you, my lecture will be about monitoring rigorously your acute stroke care, because if you monitor, then you know what you need to get better, and that's what I'll be talking about. So if I go on, yes, this is, oh, I'm probably pushing bad buttons. So this is my disclosure. So what's important, of course, we all know there are some guidelines, and we have read them sometime. We are treating our patients every day, but we usually don't have the bigger picture. So we know what we did, but we don't know what our colleagues did, and what then the whole population is treated. So there is really need of quality management, and if you want to do some quality management, you need to know what you are really doing. So this is the first step, to collect the data. You will be then horrified, but you then have some time to do some improvement programs. And then, of course, you need to improve more and more, and that's what I'm going to show you what we did in Czech Republic. So the guidelines recommend this process. That's just, I wanted to state that it's really a high level of recommendation that you need to do quality control. You have, of course, different levels of quality control. We have started somewhere between total chaos and standard stroke care. Then, of course, if you need excellent stroke care, you need to do a lot more. And what I really like, but usually not most physicians, is NSA level monitoring. Then you know everything about every patient, and then you look back at the data and try to think how to do it better. My dream as a quality manager is that every team member is internal quality auditor, that there are some external checkups coming really frequently, that the quality goals are recited by whole team every morning, and if we reach the goals, then we immediately set them a little bit higher. So that's of course not possible, and people usually don't like this approach, but at least some of them are compliant with it, as we have shown in Czech Republic. So just for you who don't know our country, it's a country of only 10 million, so it's smaller than Cairo, as we've talked with Professor Zakaria. It's a really compact country. You see 300 to 500 kilometers in the middle of the Europe. If I look about our system, so we had a system before year 2001 without any central accreditation. We had just 80 neurologic departments. Then we, as a stroke society, try to accredit the centers. So we have established some rules, but we were not really much strict about how to do it. But at least we have something like that. Who wanted to be a stroke center simply said we are a stroke center. If he was doing more than 20 thrombolysis per year, that was it, nothing more. Then we got lucky because of the activity of our society and Czech government, and mainly by EU structural funds, where we have set up a system of stroke care in 3 steps, which was then in 3 years in development, and there was a lot of papers which every center should have put into the Ministry of Health. 80 centers applied, and only 45 were chosen because they were compliant with the parameters. And as it was, those centers were then rewarded by having money from the European structural funds to be re-equipped and equipped with things they were missing. What we have managed then later on was that we started to do quality improvement programs, and we I will show you how. So we have 45 centers, 13 are comprehensive, basically doing neurosurgery and interventions. And you see that the basic characteristics are not that big, 8 beds in the primary stroke center, in ICU, 30 beds standard, and early physiotherapy, again 30 beds. What we do for quality monitoring? We collect 3 types of data. We collect all patients with stroke only twice a year for a whole month, so it's all who are admitted March and October, and we put those data in the rescue registry. Because we of course would like to have monitored all patients, but it's too demanding on the centers. But twice a year we have thought will give you a good picture. We collect all recanalized patients' data all the time. And also we collect data annually. There is more data, like in general, like on average numbers for every center once a year. I will show you some results. Those are patients admitted. It's 26,500 of stroke patients admitted into the centers. This is from the start of the compulsory triage, which we have made. So it's not changing. And from the epidemiological data and checkup data with insurances, we have noticed that we have like something like 95% of all stroke population going into the certified stroke centers. When we look at the thrombolysis rate, you see that we have started before the start of the centers, 2009, 2010. We were somewhere around 10% or even less of population was thrombolyzed. But when we started with the system, and especially when we have started with the compulsory triage, which means that if you are positive for fast, basically, and then we have some minor signs, in last 24 hours, you need to be transported to the certified stroke center. So you see that we have managed to raise the thrombolytic rate up to 20% of population in 2016, and now we are attacking 25% of whole state population of strokes. If we look at the thrombectomy, we are now above 5% of all ischemic strokes are getting thrombectomy. What we did next was not just collect annual indicators in year 2013, but we have started to do monthly reports. As Valeria has already shown, we have thought that we need more connection with the centers. They need some benchmarking and to know how they are doing. So we have started to send, with the help of angels, because this is really a lot of work and activity above the usual workload of us other physicians who are doing all the organization of the stroke network in a spare time in the evenings. So we have started to make monthly reports and sending them to centers. We did this in the summer of 2016. Then we have added gradually some other parameters of stroke care, and I will show you what. And now we are even sending more time frame data. So when we look at what we are collecting and sending back to the centers now, so it's onset to hospital also for emergency services, door to imaging, door to needle, and then in cases of secondary transfer from the primary to secondary, primary center to secondary, and also door to groin times, again divided by those categories of patients. So this is the reports Valeria shown, and you see in the beginning when we started, we were not able to finish all the centers because they were simply not putting data in time. So we are using SITS for this, and you see that 2/3 of centers were not simply following the data. What we have managed with our campaign and with Angels, you see that by the end of the year, in 6 months, we have managed that all centers are putting data. But see the labeling. The red means that the center has median time to door to needle above 30 minutes. And the green was below 30 minutes. So we have marked them such as. Then we have pushed with a lot of programs, especially like workshops, education, angels, and on-site, and also lab simulations to getting better indoor to needle time. As you see in December 2017, we have managed then, again, more than half of the centers were median below 30. And what we did this year is that we have started to label centers who are below 20 as good, and those who are between 20 to 30 in median as intermediate. So we have lifted, the level a little bit. So I think it's needed because otherwise there would be stagnation. When we look at the national data taken from the individual patients in SIDS, you see that with the monthly benchmarking, we have managed, and some other interventions, but we are really not sure. We think this is the main intervention we did. You see that we have managed to push more than 10 minutes in 1.5 years in all strokes in Czech Republic. So now we are at 26.7 minute median in all individual patients. You see, this is the curve from the SIDS registry from 2010, 2017, and you see two bumps going down a little bit faster, this curve. In 2013, we started with annual reports, and that was the first time the centers got to know how they are doing. Then they really started to work on this, and you see with monthly reports, the curve takes even stricter slope down. So we hope it will continue somehow, at least up to 10 or whatever. Now we have joined and declared as a stroke society that we will support a campaign Stroke 2020, which means that by 2020, at least 20% of all ischemic strokes should be treated with recanalization with thrombolysis, and the time from hospital admission to treatment should be reduced to less than 20 minutes. So we have already made this 20% of population, and we are working now on 20 minutes. As you have seen, 1/3 of centers is already with the median below 20, so we have just 2/3 of centers to go. What you can also use the quality monitoring is finding the gaps, not just the weak centers where you then, with help of the angel consultants, for example, can aim your attention, but also what we do in our reports is compare regions. So we look at the different regions of Czech Republic and we push them to be, the same, but of course the resources are a little bit different. What we do next, and that's my final point, we also look, as I said, for all patients with stroke for 2 months in a year, and we look at other stuff than just the time, because we know that the time is important, of course, but we also need to look for dysphagia screening, for the secondary prevention, and stuff like that. So what we also send once half a year report where every hospital sees each other hospital, how they are doing. And you see that in dysphagia screening, where we were not really good in 2016, after the report we got much better. That's the green numbers. So what were the most important factors influencing our state currently? We did such a questionnaire, really complicated, but basically it was that the network is organized centrally and that we present the results of indicators to all the in between others. So to conclude, I think you need to set realistic and well-defined quality improvements. You have to give some awards. Angels Awards are excellent example, but you need always balance between wanting to be better and being honest, so you should not push the centers too much. Thank you for your attention.